Great, thank you so much for inviting me. It's a real honor to be here this evening to speak to you. And my topic tonight is about patient safety and why it is so hard to improve patient safety. And one of the reasons for that is culture eats strategy for breakfast. Let me tell you a story. We were trying to improve healthcare worker hand hygiene at our organization for about 5 years. We tried everything to try to get healthcare workers to clean their hands. And one of the ideas was perhaps our patients should remind their healthcare provider to clean their hands if they didn't do it, which at the time I thought was a neat idea. We should, get our patients involved in their own care and things. But that can go horribly wrong. And one thing that happened was one of our patients was visiting one of our outpatient clinics and was very upset because the doctor who was coming to see them didn't clean their hands in front of them. And actually, the patient actually said, "Would you mind cleaning your hands?" And the doctor said, "Well, I did. I washed them down the hallway. You just didn't see it." And she said, "Yes, but would you mind doing it in front of me? This is something that I kind of worry about getting healthcare-associated infections. Would you mind washing your hands?" So he sort of begrudgingly pumped the alcohol gel and begrudgingly washed his hands. And then as she was leaving the clinic and booking her follow-up appointment, she said to the clerk there, "Would you mind booking me with another physician? Because that one gave me a hard time about washing his hands." And the physician heard this and yelled at them from across the waiting room, "Don't ever come back. You're out of here. You're gone." That's culture, right? You can spend your life educating people and putting up posters and doing all these amazing things, but all it takes is one powerful person in your organization, often, but not exclusively physicians, but often a physician, to say this is garbage, and you're done. It's all over. So I learned in my career that I could try to nag people and educate people and then nag them and then educate them again to get them to change, but they just didn't do it. And it was really trying the same thing over and over again and just consistently failing that brought me to this new approach that we've been using now for about 6 years. We did a study a couple years ago where we were interviewing a lot of healthcare workers in Canada and asking them, what are some of the traits of the Canadian healthcare system? And wherever I have presented this, people seem to agree that their healthcare system has very similar traits. We need to get things done immediately. Don't stop and think about it and engage people and talk about it. Just get it done. As a medical student at McGill, that was drilled into me very quickly. You didn't go to your staff physician, "Excuse me, can you explain to me why we're doing this?" It's just, shut up and do it. So get things done immediately. We love our evidence-based practice. And in fact, we use that often as a reason not to change. So where's the randomized control trial that says that I'm supposed to do A? And if there isn't a randomized control trial, I'm out. I'm not going to do this. I need my evidence to be able to inform my practice. We love our information and data. We're very fixated on that in Canadian healthcare. We're trying to measure everything these days. The problem is you can't fatten a cow by weighing it. So we're very good at weighing the cow, but we're not doing anything with the information. We all learn that culture change is complicated. I took a diploma with our business school at University of Toronto several years ago, and that was probably the number one theme that I heard. Oh my God, if you want to change culture, this is going to be awful. It's going to be hard. You're going to be throwing yourself against the wall over and over again. We're all about our leaders needing to step up. At my organization, we're rather fixated on leadership. We always need our leaders to, get up there and lead. Everybody else is supposed to follow them. In particular, physicians are meant to always be leading rather than following or asking questions. And the problem with that, of course, is, we don't actually always know the answers. I know that may be a shock to some of you, but we actually, as physicians, we don't always know the answers to things, but we're always expected to lead. So that can be very difficult. We have very strong hierarchies in medicine in Canada, where essentially, there's different groups that speak to different groups, and a lot of groups don't actually intermingle with each other, and we tend to have a very top-down approach to things. Somebody says something on top, and it filters down to everybody else. Does this resonate Okay, so we're similar that way. We really like thinking of healthcare as a very linear, logical, organized, and very sort of predictable thing. If you do A, you will get B, right? Very organized thing. There was a fairly famous article that was published in the where was it? In the New Yorker magazine about maybe about a year ago or so, talking about why isn't American healthcare more like the Cheesecake Factory, which is a big American restaurant chain. And the author who wrote it, who was a surgeon, talked about how when you go into any one of these restaurants, or you could say if you go into any McDonald's or any Burger King, you'll always get the same thing. And the burgers are always made the same way, and everything is organized and orderly, and it just flows so beautifully. Why can't healthcare be like that? Well, sadly, there are parts of healthcare that are like that, but sadly, the main reason why it can't be like that is because it's infinitely more complex than making a burger. All you have to do is walk onto a medicine ward, and it looks like organized chaos. There's different people coming in, talking about different things and different roles, and every single patient is unique, and every family is unique, and it's nothing like an organized restaurant chain. So in fact, much of what we see in healthcare actually looks like this. Something happens, a whole bunch of stuff happens that's very hard to measure and very hard to understand, and you can't really predict, and then you get an outcome. So we love this organized, clean world. If only people were robots, that would be perfect for us. Sadly, this is often what we face in healthcare. It's a very complex system. So one of my colleagues, Brenda Zimmerman, who works at York University in Toronto, came up with this classification of the problems that we face in healthcare or in life in general. She divides them into simple, complicated, and complex problems. So the simple problem would be baking a cake. Or making a hamburger at a Burger King. You follow the recipe, you're going to get a cake. No surprises. If it doesn't work out, you're going to tune the recipe, and you will get the cake. A complicated problem is like sending a rocket to the moon. Many more variables involved, a lot more risk, maybe things won't work out, but fundamentally, if you get your math right, you can get to the moon. A complex problem, she describes, is like raising children, where there's all sorts of variables going on that you don't even know about, friends they have that you don't know about, things they're interested in, personality traits, etc., that are very different, and they're actually unique to each child. So how many of you have read the Irish best practice document for raising your kids? You've all read that one? Very standardized approach, all exactly the same. The reason it's funny is because we all know that would be impossible because there's so many things going on. We may be able to agree on some simple rules, though, with raising children, right? We may agree that, what are some simple rules for raising children? You have to love them. You have to feed them. They should probably get educated. Should probably wear clothes. After that, it starts to fall apart, and we start to disagree with each other. What kind of school, what kind of food, what kind of clothes, etc. We start having infinite variations, but there are some simple rules that guide child rearing that would probably be universal throughout the entire world. But it's highly complex. It's not a linear system. Much of what we deal with in healthcare, sadly, is over here. It's very complex. When you're dealing with simple problems, there's very standardized solutions for those simple problems. One size fits all. If I give you a cake recipe, it's going to be the same cake recipe in Ireland as it is in Canada. There's not going to be any differences in it. You can follow the same recipe and you're going to get the same result. This is the world where we're trying to standardize, minimize waste, make everything absolutely the same. That's why all Burger King restaurants are exactly the same. They're standardizing, they're minimizing waste. This is the world of problem solving, of checklists, of best practices, where you're just all doing the same thing. We love this world. It's very comforting. It makes sense with sort of the medical model of doing things, trying to reduce things down to their bare essence and doing the same thing every time. Sadly, this is not the world we live in for large parts of healthcare. This is the world of the assembly line. Now, there are parts of healthcare that are very much like this. If you're running a large surgical center where you're doing 2,000 knee replacements a year, it does start to look like this. You're trying to minimize waste, have all the right instruments, have all the right kits. Everything is timed to the last minute. That makes perfect sense. But then there's other parts of healthcare where this completely falls apart. In a complex world, we use very different approaches, and there's very different challenges. The first thing is the so-called social immune response. So what's the social immune response? Have any of you experienced bringing an idea from somewhere else to your organization and saying, hey, this worked really well over there, I want us to do this? Have you ever heard them say that's not going to work here? That's not the way we do things. A good example in Ireland might be the NHS in the UK comes up with a brilliant idea to solve problems in the Midlands, and somebody brings it over to Ireland, and the first thing you're going to say is, yeah, we're not going to do that. In Canada, we get it from the States, right? People from other places bringing in ideas, and people push back. Now, if I brought you a cake recipe, you probably wouldn't push back, right? So one of the hints of a complex problem is something that you're actually attached to. This is something that actually has meaning to you, and somebody from the outside is telling you what to do. You can even get a social immune response in the same building. How many of you have experienced 2 medical wards or surgical wards right beside each other where what works on one is definitely not going to work on the other one? And if you even tell the people on the other ward that it came from the first ward, they will definitely not want to do it. That's the nature of human behavior, right? Stuff coming from outside is seen as foreign, and we start to push back. In a complex world, one size never fits all. Remember what I was saying about, again, raising children. There is no best practice document on how to raise your kids. They're always going to be different. There's always going to be nuances in what you're doing. With complex problems, there's no one big fix. You nibble away at them. There's no one thing you can do to make it go away. The example I was giving yesterday was I was doing some work in the center of Canada in Saskatchewan, and we were talking about trying to improve hand washing amongst physicians. Because, guilty, we're not really that good at cleaning our hands. No matter where you go in the world, physicians tend to lag behind everybody else. I have a story about that. I mean, one of the reasons we lag is because nobody ever told us to do it. I realize we're telling people to do it now, but when I was a medical resident in Montreal, I would round on 35 patients every morning and never clean my hands once. Nobody pointed it out to me. Nobody told me that was important. It just wasn't something we ever concerned ourselves with. We concerned ourselves with the individual patient and their management and their care, not about the fact that I was spreading MRSA gleefully from patient to patient. Nobody ever pointed that out to me. So when I was there in Saskatchewan talking about trying to get healthcare workers to clean their hands, one of the surgeons there said, if we just had one of those 24-hour-a-day surveillance systems, you could put a camera in every single room, and you could watch every person clean their hands or not clean their hands, and if they didn't, you could do something about it. You could get in there and tell them to clean their hands, and that would dramatically improve hand washing. And I thought to myself, would it? Is that really going to solve all of our problems? First of all, I would guess some of the healthcare workers are going to knock the cameras off the wall. That would be something we would do for sure. But also, the dispensers still have to be filled. You still have to clean your hands at the right time, etc. With complex problems, there's no one big fix. But we get stuck on that all the time because we're looking for the big fix. We're looking for the one thing that would make it all go away. With complex problems, you can have paradoxes. And I will tell you some stories over this evening that worked very well in one place, but would be exactly the opposite thing you would do somewhere else. So you can think about how many of you have more than one child? Do you treat them all exactly the same? They have different personalities, right? Could you think of a time where what you would do with one child might be the opposite of what you do with the other one because of their personalities. It happens. With complex systems, you can have paradoxes. Social proof matters a great deal with complex problems. And what social proof is, I've seen it with my own eyes and I know it works. Therefore, I'm going to believe in this. That's very anti-evidence-based medicine. Evidence-based medicine says, here's the evidence, you will change your behavior based on the evidence. Yeah, if that was true, nobody would smoke. There's clearly more motivators going on than that. The evidence for smoking being bad for you is, you're sticking burning leaves in your mouth, for God's sakes. That can't be good for you. There's other reasons why people smoke besides just that. But social proof in complex problems matters a great deal. Lastly, in complex problems, relationships trump everything else. So for those of you who work in patient safety, you probably have had the experience where some places you work with, it just seems to work really well, and other places it's a total disaster. I guarantee you, if you start to drill down and figure out what that is, the place where it works well is because you have good relationships with those people. You get along, your personalities just sort of click with each other. And again, that is not something we typically talk about in evidence-based medicine. So what we've been doing is we've been applying a lot of the concepts of medicine to patient safety when we should actually be applying the concepts of sociology and anthropology and psychology to patient safety. Because this isn't about medicine, this is about human behavior. So we've been basically trying to stuff a square peg in a round hole, and we just keep doing it over and over and over again because that's what we're trained to do. Another point I want to make, which I love these pictures. If you go onto Google Images and just look for pictures of doctors, they're always standing in front of people. We don't know who those people are because they're not doctors. And the doctors are usually looking like this. One of our hospitals in Toronto, now this is on YouTube, I'm going to get in serious trouble for saying this, but one of our hospitals in Toronto was doing a lot of advertising for our hospital foundation, trying to get money from the community to help do whatever it is they do. And along the wall, along the street, are only pictures of doctors. And none of them are smiling, and they're all like, yeah, I'm really something. And of course, don't get me wrong, doctors are very important in healthcare, but a lot of people are important in healthcare. In fact, when you talk to patients, their relationship with the doctor is important, but their relationship with everybody else is equally, if not more important, because they're seeing more of them. One thing we hear over and over again from patients when they're inpatients is, in fact, the best relationship they form is usually with the person who comes in to clean their room every day. But they're not standing on the front of the hospital like this. It's really doctors, and we've created, frankly, toxic hierarchies. So why do I say they're toxic? We have such hierarchies in medicine that it's very hard for people on a team to actually challenge what a doctor says or what a doctor does. And the airline industry had a very similar challenge in the 1970s. There were a lot of airplanes that were crashing every year. And when the FDA in the US looked back at why these airplane crashes were happening, it wasn't because of mechanical failures, it was because of interpersonal relationship failures. And there's some crazy stories about airline crashes that if you read, you will never want to get on another airplane again. One story involved a flight coming from Korea going to land in Guam in the middle of the Pacific Ocean. And the pilot was tired. This was a Korean Airlines flight where they had a really extreme hierarchy. The pilot was God and everybody else was everybody else. And they're coming into Guam, and there's this big gray black thing in front of them because it was nighttime and the radar was out and things. And the co-pilot could clearly see the fact that they were flying into a mountain. And he was kind of hinting, there's a big thing in front of us. Maybe we don't want to hit that. We should just kind of go around it or over it. And the pilot wasn't paying attention. He was caught up with other stuff. And the co-pilot let the pilot fly the airplane into a mountain rather than challenge and say, what are you doing? Lots of stories of people knowing that the surgeon was cutting off the wrong limb, but not wanting to challenge them on that. There's a lot of similarities between airline culture and healthcare culture. So what they did in the 1970s, one thing they did was come up with checklists, which healthcare was all over. Oh my God, give me your checklists. That's a genius idea. We're going to follow checklists to improve patient safety. That's a good idea, but it's not the only thing they did. The other thing they did is they forced their flight crew to talk to each other, like literally forced them. And the pilots were not happy about this. This is stupid. Why should I be talking to other people? I'm the boss. This is a waste of time. But they basically trained them that if the co-pilot had a concern, they were obliged to tell the pilot, and the pilot was obliged to turn and acknowledge the concern and ask, what can I do to make you feel more comfortable about this? This was drilled into their heads, and the crashes went away. This program was called Crew Resource Management, and what they did, these are some of the concepts. To lead by listening. You are expected to listen to others around you. You have to get input from everyone. It doesn't matter whether they are the flight attendant or the air crew or whomever, you have to get their input. You have to use everybody who you can actually speak with, and you have to make decisions based on all the available information, which means listening to everyone. I had a very unique experience. I was flying back from Vancouver to Toronto about 6 months ago, and I got upgraded to business class, which was nice, and I walked in to sit down, and there was no seat. Somebody had spilled chocolate all over the seat, and so they asked me to sit in the cockpit while they were getting a new seat. And so I sat in the cockpit, and I got to watch them go through their checklist and things. And one of the things that happened was the pilot was concerned about the air in one of the tires, and so he called the flight crew. So the flight crew guy comes in, and he's got dreadlocks, and he's got his headphones on, and his grubby orange suit, and his construction boots, and he walks in, and you could sense there could be a huge power differential, right? You've got this pilot here, everybody worships the pilots, and this flight crew guy. And the pilot says to him, I'm very concerned about the air level. Can you please remind me what the relative standards are? Because you're the expert in this, and I really want to hear your opinion on whether it's okay for us to fly. And it was really striking, because how often would that happen in healthcare? So the guy tells him, and then the pilot says, thanks very much, I really appreciate your input, that's really fantastic. And he treated him like an equal. He treated him like somebody who was integral to the team, which he is, because if we needed to change the tire, I hope they would change the tire. But you could easily see 30, 40 years ago how that conversation wouldn't have happened that way. He just would have done whatever he needed to do. So crew resource management transformed the aviation industry by forcing people to talk to each other. Remember that complex slide I showed with the relationships trump everything else? The last point of this is to establish psychological safety so people feel comfortable in sharing their insights and their information. So I'm not going to get my head ripped off if I ask you a question or I challenge what you're doing. And I go back to being a medical student where I would never, ever ask my staff physician, why are we doing this? Never. I would get my lungs ripped out. You just don't challenge authority. So we have a long way to go in terms of our culture within healthcare to build those relationships which are so important to patient safety. I have to tell you this story. This is a little 737 that was flying from Honolulu to Maui. Have any of you been to Maui? Is that not the most amazing place? All of you, seriously, should go to Maui. It is an unbelievable place. Fantastic coffee there. So this is a little airplane which is hopping islands going from Honolulu to Maui. And as they're climbing, the entire top of the fuselage rips off, and people from rows 8 to 12 who weren't wearing their seat belts get sucked out. So the plane obviously is incredibly unstable at this point. And The manual says that when you get a very severe depressurization incident like this, the first thing you're supposed to do is seriously drop altitude so people can breathe. The pilot is doing this, and the co-pilot says, we can't drop altitude. The pilot says, why? Why can't we drop altitude? He says, because we're already losing altitude as we're flying in, and if we hope to land this, we need to stay as high as possible because we're dropping like this anyway. So don't drop us faster. So on discussion with the flight crew and the co-pilot, they completely overruled what their manual said they were supposed to do to be able to land the plane, and actually landed the plane and saved about half the people on that plane. And the pilot came back later and said, if it wasn't for crew resource management, he never would have asked the opinion, he just would have done what he needed to do, and they all would have died. So it's just a great example of having those conversations can bring about remarkably different outcomes. How many of you have seen the famous Cotter change model? It's that multi-step model where you start with create urgency, oh my God, we're all going to die, and then, form a powerful coalition, usually of senior leaders, with people with, important stuff that have clipboards, create a vision, communicate the vision, empower action. This often doesn't work in healthcare. Usually right around here, people go, yeah, I'm not going to do that. Have you ever seen change things in your organizations, get this big hype, they get going, and then they just die? Very common in patient safety. This often doesn't work. And one of the reasons it doesn't work is because we're not getting this middle part right. This is very top-down driven, this model. As I said earlier, when you're dealing with complex problems, you nibble away at them. Little tiny changes in behavior all over the place will combine to bring for a really amazing positive outcome. For those of you who are interested in reading books, I would suggest you read the book called Getting to Maybe. One of the authors is Brenda Zimmerman, and it's a story about unbelievable changes that have occurred because people have just started to act differently. It's a really great, nice sort of description of complexity science and how you nibble away at various problems. I mentioned this already. In the very complex world, we like to talk about minimum specifications or simple rules. What are things we can all agree on? So if you think about patient safety in Ireland, I've only been to Dublin 3 times, but I'm pretty sure that what happens in Dublin is not identical to what happens in other parts of the country. And in fact, if you brought ideas from Dublin to other parts of the country, they may be pushed back at because you're not all the same. Different regions have different challenges, different things that they're dealing with. But you could probably all agree on some simple rules. So when we were trying to improve hand washing at our hospital, even our wards were different, right? They're all different personalities. But we could agree on simple rules. We're all going to use the same alcohol gel. We're all going to audit the same way so we can actually compare our numbers back and forth. We're all going to have alcohol at the point of care, but I don't care where you put it. It has to mean something to you, not to me. After that, I don't care what you do to improve hand hygiene. Just do whatever works for you, but these are the simple rules we're all going to agree on. Think back to the simple rules of raising children. Love them, give them clothes, feed them, etc. We tend to get very caught up in this, right? When we roll out a patient safety program, it's often a very detailed list of all the things you have to do, and that's what people start reacting to because it doesn't fit with their local environment, rather than just saying, these are the simple things we all agree on, and after that, do whatever makes sense to you. So when we're trying to improve safety, we often approach it from 2 different ways. One is prevention and one is resilience. So prevention, I'll just go back here. So prevention is the thing we know and love, prevent the thing from happening. So let me tell you a story about that. So we had the good fortune of having SARS in Toronto. Actually, SARS did amazing things for my field of infection prevention and control. I used to joke that infection prevention and control had the same status as a shrub on the front lawn of the hospital. And after SARS, suddenly we became very, very important. because it was an infection that was spread in hospitals. Half of our patients were actually healthcare workers that caught it at work. And one of our ways of controlling it was to screen everybody who came into the hospital. So you would show up, it was March, so it was below zero. You'd be standing outside in the cold, and you get in a single line, and you would come to the front of the hospital, and somebody would immediately take your temperature, which was always, sub-zero because we're freezing to death outside. And then you would walk in, somebody would squirt alcohol gel into your hands and watch that you washed your hands. Then you would fill out this questionnaire that said where you had worked, if you had been in any contact with SARS patients. And I had once been asked by our ministry to go visit another hospital to see how they were doing. So I checked off, yes, I had visited one of our hospitals that had an uncontrolled SARS outbreak. And literally security almost threw me out the door. Like, it was this whole system designed to keep people like me out of the hospital. If you managed to get through the whole gauntlet, they gave you a respirator, gave you gloves, and you went off to work. If you were a visitor, you weren't allowed in unless somebody was within 24 hours of dying, which is often hard to measure, so you can imagine how hard that was. And if you weren't absolutely essential as a healthcare worker, you weren't allowed in either. So the classic prevention model. The problem with prevention is there's always holes in the wall, right? You can be doing all of this work for preventing patient falls, looking at high-risk patients who are at high risk for falls, but they're still going to get out of bed when you don't expect it. So what's plan B? If you put all of your eggs in this basket, what's plan B? Plan B is resilience. The idea that your team, everybody on the team cares. So with that SARS example, it would be if that person came to work sick, everybody would look at a healthcare worker coming to work sick and saying, stop, you shouldn't be here. You should, go home. And in fact, that's what happened in our hospital. We had one of our workers came to work ill, had taken aspirin the day before, taken aspirin that morning, so they didn't have a fever, lied through screening because they actually did have symptoms, and spread SARS to 4 other people. A resilient team would notice that person and say, you shouldn't be here. They would all be escorting them out of the building. Some of the work we do is in upstate New York, and one of the hospitals we were in has a system whereby if the call bell light goes on outside of a room, no matter who you are, you have to go in and see what the patient wants. Doesn't matter if you're a housekeeper, if you're the guy fixing the light fixture, if you're a physician, a nurse, it doesn't matter. You have to go in and see what's going on. And they did that to try to prevent falls. You would sit with the patient and chat with them until the nurse was available to come in and actually see what the patient needed. That's another resilient team. Another example of resilience, after we had done a lot of work in hand hygiene, one of our lung transplant surgeons left a patient's room without cleaning their hands. And one of our housekeeping staff stopped them and said, "Doctor, you forgot to clean your hands." And you can wonder which way that's going to go. And the surgeon said, "Thank you, I forgot," and cleaned their hands. If you go back 4 years before that, one of our pulmonologists walked out of a room, didn't clean their hands, was wearing gloves, took the gloves off and didn't clean their hands. And one of our housekeeping staff stopped them, and they proceeded to ball up their gloves and throw them at the head of the housekeeper. That's not a resilient team. So we've moved a long way since then, where a member of our housekeeping staff can feel confident to say to one of our premier surgeons, you need to do this. So that's what we're trying to create, is resilient teams. This is a social network map. One of the tools we use to try to see what's going on with various teams and things is we actually do social network mapping before we start our work to see who's talking to who. So we ask people on a particular nursing unit, who do you talk to today about superbugs or C. difficile or MRSA, whatever it is? Who do you speak with today? And all the purples are nurses. So the nurses are talking to nurses. The housekeeping staff are way out here. Nobody's really talking to the housekeeping staff, which is interesting because they have a major role in actually preventing C. difficile. It can live in the environment for months. So cleaning is actually incredibly important. And there's only about 2 doctors on the entire map. Nobody talks to them at all, and they don't talk to anybody. It's a lovely snapshot of culture. This is the infection control practitioner. So she's a bit off to the side here, But obviously, a lot of people are talking to that person. If that person goes on holidays, what happens? Presumably chaos. Who knows what happens when that person goes on holidays, which again implies it's not a resilient team. If somebody gets pulled out, a resilient team would just pick it up and continue on. This is what their map looked like after we did 18 months of work with them, where they actually improved interconnectivity between team members by 88%. This is the infection control practitioner. But now you see a very dense core of people who are all talking to each other. What have we done? We've built relationships. There's actually doctors on this map. There's even some doctors near the center. Doctors who never talked about this before are now talking about it. So it's one neat way you can measure changes in culture. This particular hospital is remarkable. They have reduced C. difficile to almost zero. They don't really have MRSA transmission anymore. They have done phenomenal things. They have what I would say is the best antimicrobial stewardship program I've ever seen. And it was all built on this philosophy of engaging people to figure out what's going to work with them. What's really neat about this place is, this is again, who do you work with to control superbugs? This is the CEO of the hospital. He's actually near the center of the network. These are several key physicians who are near the center of that network. It shows that if you get the whole system together, you can really have phenomenal results. So the approach we use is called Frontline Ownership, and it's exactly what it says. When we want to improve patient safety, we engage the people who are actually touching the problem. So if you're dealing with patient falls, we deal with the people who are on the ward working with patients every day. We're not looking for buy-in. Buy-in is a very popular word in the US these days, which is about, I come into a room, I tell you about a new thing, you all nod in agreement, and then I leave the room and you say, we're not going to do that. That's buy-in. What we're looking for is actually true ownership, where people truly believe in what they're doing. And the reason why it's actually sustained is because these are their ideas and they're moving forward with them. This comes from the concept of positive deviance. And what positive deviance is, it's sort of it's a naturally occurring social phenomena where there are some people in any group that are just outperforming everybody else. They don't know they're special, they're just doing different things, which makes them better at doing what everybody else is doing. So in this audience, some of you may be better at juggling your work life and your home life schedule. Some of you may be better at paying your bills on time. Whatever it is, you'll see positive outliers and negative outliers. In patient safety, we tend to focus on these people. But what I'm suggesting is we should focus on these positive people and get them to share their ideas with everyone else. So this positive deviance approach has been used all over the world to control or to help tame very difficult problems. The most famous example is from Vietnam. This was done in the 1970s. A group from the School of Nutrition at Tufts University in Boston were invited to work with villages in Vietnam to help basically improve childhood malnutrition. It was right after the Vietnam War. The country was very, very poor. And they invited this group from the United States to help solve malnutrition. And they were given the following marching orders. They had to do this within 6 months. They had to do it for free. And it had to be sustained after they left. And you could imagine that seems almost impossible. But one of the key things about this work is it's not about those experts, it's about the community itself. What they did was weigh all the children and found out there were some kids who were doing really well, found out what it was about those children, and then basically spread those ideas virally to other families. What they found is those families were feeding their children more often. Instead of one big plate of food, they were getting 4 little plates of food. They were actively feeding them by shoving the food in rather than watching the toddler spray it all over themselves. They were feeding them different foods. And so what they did is they kind of let those stories be known to everybody else in the village and allow them to adopt them on their own time frame. It's very different from what we would do in healthcare. If we had a very high-performing organization in healthcare, we would go over here and say, that's brilliant, we should type up some PowerPoint slides, a couple memos, and make everybody else do that. And that's when it falls flat, because you're forcing those ideas on people rather than letting them percolate virally. So it's been used to try to solve inner-city violence amongst children. It's been used for smoking cessation in prisons in Australia. It's been used for medication reconciliation. Here it was kind of neat. What they did is they found out there were some patients who actually knew which medications to take when they went home. Why? Why did they know that? They found out they were doing simple tricks to remember them. It turns out the healthcare workers who were giving them their medications were often giving them in their own language. There often was a family member present. They learned there were a variety of behaviors which helped patients know what medications to take, and then they spread those behaviors virally. Again, rather than telling people what to do. They improved medication reconciliation by essentially 50%. All of these stories, we've also used it for superbugs to try to control the spread of MRSA and C. difficile. All of these stories, change came about from the community itself, not from an outside expert telling people what to do. We use techniques called liberating structures to help engage people. So we'll do one of those now. This one is called TRIZ. It's the theory of inventive problem solving in Russian. That's why that doesn't make any sense to you. And what it is we're essentially trying to create a system that's exactly the opposite of what you want to achieve. So just yell out some ideas. How would you ensure that every patient in your healthcare facility falls and breaks a hip? How would you make that happen every single time? What would you do? Push them, I heard. That's nice. What else? Sorry? Yeah. What else? Really high beds. Make sure the sides are down. Slippery floors. Don't feed them so they get weak. That's a nice one. Keep the floors wet. Yeah, my personal favorite I heard once was keep the call bell 2 inches away from their maximum reach so they reach and then fall. Give them a lot of benzodiazepines at night, get them all drugged up. Make sure they all have catheters. You get the idea. So instead of giving a typical education session to people, I will go in and actually ask that question on whatever the topic is. So let's say I'm talking about pressure ulcers. How do we ensure every patient in this organization gets a stage 4 pressure ulcer guaranteed? What would you do? List out all of the ideas. That's step 1. Step 2 is, which of these things are we currently doing to some degree? And the answer is usually about 80% of them. Once in the US, somebody said, give the patients roller skates. I mean, we're not doing that. But chances are we are putting obstacles in their way, or the floor might be wet or slippery or whatever else. So you go through that, you find out that 80% of these things are currently happening, and then the last step in this approach is to say, is there anything on this list that's within your power today that you could start to change? So you can imagine, if you're housekeeping staff, you could say, well, yeah, I could make sure that when I finish cleaning the room, that I get all the obstacles out of the way. And if you're a physician, you might say, I will quit prescribing every single person Haldol and zonking them out at night. Or I'll make sure not to give diuretics at 11 o'clock in the evening. The nursing staff might say, before the patient goes to sleep, I'll make sure the call bell's right there. I'll make sure the bed's at the right height. All of us own a piece of this, and you can imagine if we all start changing those things, we're nibbling away at patient falls. We're making it a little bit better. So that's one of the liberating structures we use. There's 30 of them. You can go to liberatingstructures.com. It's a very flaky website, I'll tell you right now. It's kind of hard to wrap your head around some of these things, but they work very well once you understand how they're used. So, in essentially what I'm saying is, if you want everybody to get to here, be it decreased falls, decreased pressure ulcers, fewer urinary catheter-related infections, better hand washing, fewer pressure ulcers, whatever it is, and your teams are over here, you might set some of these roads are your minimum specifications. Okay? So again, as I said, for hand washing, we might say, we're all going to use the same product. We're all going to audit the same way. We're all going to measure the same way. But after that, you let them take whatever roads they want as long as they get to there. So in a sense, what you're doing is you're allowing people to rebuild the wheel. If you have 3 teams in front of you, the first team might come up with a way that works for them, but rather than taking that idea and forcing it on the others, you allow the other 2 teams to come up with what's going to work for them. Essentially, you're letting them rebuild the wheel. This is the opposite of what modern medicine wants us to do, because they want us to say, get rid of waste, do it all the same way. But we're not working at Burger King. These are human beings, they're not robots. They need to own it, they need to figure out what works for them, and then they're going to come up with their own path. So the role of leadership is to define what the wheel needs to do, not what it looks like. So I don't care how you got patients' falls down on your unit, as long as you get them down. Whatever's going to work for you. And I'll give you a bunch of examples now to show you how that works. So the principles of this work: we work with people who want to work with us. We don't bang our heads against the wall for people who are actively hostile. We work with people who are interested in trying something new. We've learned that change spreads in infinite ways, so there's no preconceived idea of how ideas will spread in an organization. Every organization is different, and we use the existing ways of spreading information depending where we are. We make the invisible visible. If there's something obvious that nobody wants to talk about, we'll talk about it. We once gave a workshop at one of our downtown teaching hospitals where they invited housekeeping and nursing staff, and you will already know the answer to this. The nurses came in and all sat in one row, and where did the housekeeping staff sit? Behind them, right? Yeah, behind them all in a row. Did they talk to each other, the nurses and the housekeepers? No, they didn't. So we actually point that out. Think back to the airplane. We're forcing the crews to all speak to each other because relationships trump everything else when you're dealing with complex problems. We invite everybody. So if we're dealing with a patient safety issue on one floor, we will invite whoever's interested. Doesn't matter what their job title is. We have seen some of the best change ideas come from people who have never been asked for their ideas. We once heard from a housekeeper in Vancouver who told us she's been cleaning patient rooms for 25 years and no one has ever asked her opinion on how to do it. No wonder people are disengaged and they're not interested. We're not listening to them, we're not talking to them. You have to allow people to kind of wrap their heads around this and spin their wheels a bit before things start to get going. We're working with one hospital in New York State where it took them a year of just going around in circles until finally one of the key positions in that organization changed. They brought in a new director of nursing, and this hospital has exploded with all of their patient safety ideas. It is unbelievably gratifying to watch. They just weren't ready to change yet, but as soon as they brought a new person in, we had been there working with them, and it just exploded. Nothing about me without me means if you're in a room and people start saying, "Why are you talking to me? It's the doctors who aren't cleaning their hands." If there's no doctor in the room, you can't continue the conversation. So you say, "We can't talk about that. There's no doctors here. Next time, bring a doctor. Then we'll see it from their perspective what's going on." So again, you're forcing the communication, the relationships. Act your way into a new way of thinking is simply social proof, the idea that you've seen it with your own eyes and now this thing makes sense to you. And finally, things may get worse before they get better. So once you've been doing this for a while, you may start to notice all the problems and your numbers may get worse before you finally get a handle on them and start to make them better. So it's quite different from our usual sharing of best practices. In frontline ownership, the practices are highly sensitive to where you are. They come from the people who are touching the problem. They're spread virally, and they tend to be sustained. When you do it in our sharing best practice model, what we say is, it worked over here, you should do it too, and if you can't do it, there's something wrong with you. Winning practices come from experts in the sharing best practice model. Practices are forced on people, and they're often not sustained. So in the end, the best practice that you talk about here will be adopted by these people, but they're going to make it their own. And as long as you agree with the simple rules, you'll have different approaches to the same problem. So the work we do is about the how rather than the what. If I was to go on the street right now and ask people, how would you spread bacteria to every patient in the hospital, lay people would have a very good understanding of how that happens. I've actually done this, not on the street, but in lectures like this with the public. They all have a very good understanding of how we're spreading things in hospital. It's not a problem of what the problem is, it's how do you change people's behavior, and this is all about the how. So some examples, we tried improving hand hygiene in our organization. We went on for 3 or 4 years trying to improve it. We got nowhere. We tried to take a lot of ideas from other hospitals. One of our ideas was to give out coffee gift certificates to people who were caught cleaning their hands. Sort of a positive reinforcement thing. So if I saw you washing, I would give you one of our gift certificates and you would look at me like I was crazy, but then hopefully that would be a positive message. One of our staff complained to our national newspaper. The newspaper wrote an editorial on that about how we were bribing healthcare workers to do things that they should have been doing anyway. They even had an editorial cartoon of a nurse cleaning their hands and scrubbing all of the like skin off their fingers. They were just, like bones at that point because they were hooked on coffee. People wrote letters to the editor about how, because we're Canadian, we're all going to use that to buy donuts rather than use it to buy coffee. It was a complete disaster. We made posters that I thought were hilarious, because I made them. We made posters, posted them up along the walls, and staff would tear them down. They didn't like the posters. You see the key thing in all of this? It's me implementing my idea, and it's hitting a wall, and it's crashing. So you can get the tools and the education and the audits and the reminders, and then you smack into culture and you go nowhere. That was here. Since then, this is what our hand hygiene compliance has done. In 2014, we're at about 95% compliance. I'm the first one to admit that 95 is not a real 95, because having a person standing there watching you clean your hands biases your results. But we've used the same auditing throughout. And when you walk on our wards now, you notice a dramatic difference in hand washing behavior. People are cleaning their hands all over the place where they didn't used to before. So how do we do this? These are the examples that hopefully will drive home how this worked. This is Olga. She's the nurse manager on our orthopedic surgery floor. Olga had no idea how to improve hand washing. What we did is we audit every unit. Those data are shared transparently across the organization. They're also posted on the wall in public, and they're on our public internet site. So everybody knew how everybody else was doing. We told the managers, in the first year, you have to get to 50% compliance. Good luck. Not telling you how to do that. I don't know what's going to work for you. We're there to support you. If you want posters, we'll get you posters. If you want this, if you want help with the alcohol gel, we'll help you. But I do not know how to motivate your staff, but I bet you do. So what Olga started doing, she would round with the orthopedic surgeons in the morning at 7 a.m., and if they didn't clean their hands, she would wash them for them. And it was fit perfectly. She had a very sarcastic, funny relationship with her surgeons, and they loved it. They thought it was hilarious. So she would pump the gel, and if they didn't want it, she'd wash their hands like literally for them. And then after a while, she could wave the alcohol gel, and they'd all laugh, and they'd all clean their hands. And the medical students and the residents were all in on it as well. They would clean their hands. And then one of the orthopedic surgeons came up to me and said, I don't believe that we're doing as bad as you say we are on this unit. I don't believe you're auditing data, because we're washing our hands all the time, and you're telling us that we're at 69%. How can that be? Rather than arguing with him, which is what I used to have done, I actually engaged him and I said, well, why don't you audit with us? We'll meet you at a time when it's convenient for you, spend 5 minutes with us, just 5 minutes, and see what we see. So we audited with one of our auditors for 5 minutes and saw that a whole bunch of people were not cleaning their hands. He suddenly had social proof. He'd seen it with his own eyes that suddenly the data we were presenting were actually probably true. After that, a whole bunch of stuff happens that I can't measure and I can't understand and I can't tell you what it was. Fast forward a year later, they are consistently the most hand-washingest, if that's a word, in our entire organization. I have had staff, one of my infection control nurses, her husband was actually admitted to that ward with a broken arm, and she told me, you know, you're not going to believe this, but people have invented new moments of hand hygiene I've never heard of on this unit. They're all washing their hands and reminding each other. It's this whole thing. You can almost see the resilience of the team. I was giving a talk at one of our doctor leadership courses in Ontario, and one of the anesthesiologists in the room actually had seen patients on that floor, and he stood up and said, "You're right. Within a minute of going on Olga's floor, you know you have to clean your hands." That's a resilient team. Where am I in all of this? I'm nowhere. They're doing it themselves. I'm not standing there with a whip saying, "Damn it, be more resilient." They're building it themselves because it started with Olga cleaning people's hands. Another story, this is from a story from our cancer hospital where one of our problems when we first started improving hand washing was the fact that these gel dispensers were always empty. You'd go dispenser to dispenser to dispenser, not get any alcohol gel, and get very frustrated after a while. We knew about these tabs. They're free. They come from the company, and basically the idea is if you notice the dispenser is empty, you're supposed to flip the red tab up so that facilities will come by and put a new cartridge in. We tried to force this idea on our hospital for years, and they said no. Nobody knows what that means. It's too small. People won't see it. Up, down, who knows? It's a waste of time. We start engaging our frontline staff. One of the frontline staff suggests, hey, why don't we put these tabs on the top of our alcohol gel dispensers? It's the same idea we had 5 years before, but now it comes from them. We said, that's a great idea. We'll get you the tabs. They installed the tabs on all of the dispensers in that hospital. Because our hospitals are highly competitive with each other, they installed them across our entire network. The dispensers are never empty anymore. They're always full. Here's the catch. Do you think it's because of the tabs? I'm not even sure they use the tabs. I'm not even sure anybody knows what they do. It's not about the tabs. It's not about the what, it's the how. I think what happened is these facility staff finally realized they have an incredibly important role in patient safety, and now they're looking out for empty dispensers. This is just an example of a fairly busy emergency department. Our emergency department was going on and on about how they have no time to clean their hands. We're too busy, emergencies coming in all the time, we need a lower target than everybody else. And I said, no. Every month, the hand hygiene audits would come out, and they'd be at the very top, which is the worst. We went from worst to best. They'd be at the top every month. Every month, they were getting more and more embarrassed. And they finally called me and said, what can we do? And I said, I don't know. I don't know what you can do, but why don't I come down and talk to you? So I stood with the emergency room medical director at the side and said, why don't we just observe for a few minutes and see what's going on? He would see his emergency room staff entering in stuff into the computer, picking up the blood tubes, walking past multiple alcohol gel dispensers on their way to take blood from the patient, not clean their hands, not put on gloves, put the tubes back in their pocket, walk past multiple alcohol gel dispensers, and he realized, oh my God, we have tons of time to clean our hands. And you could see the myth sort of go poof. After that, things started to change on that unit. They came up with a program called the FROG program, Friction Rubs Off Germs. I do not, for the life of me, understand it, but it involved giving plastic frogs to each other if you cleaned your hands. I don't know what they were doing. But you can imagine, none of these programs are actually transferable. I can't send a memo to my nurse manager saying, from this point forward, you will all wash your doctor's hands. I would get lynched, right? I can't say, from this point forward, because it worked in the emergency department, you're all going to give plastic frogs to each other. So we don't have a hand washing program at our hospital. We have about 25 hand washing programs. They're all different. They all grew up organically on those units. Last few words, this is a collaborative we're leading in the United States. We're working with 14 hospitals there, and it's a collaborative about anything. So we're not focused on one patient safety issue, it's any patient safety issue. So we could be, hospitals are working on falls or pressure ulcers or hand washing or surgical site infections. What's common to all of them is the approach that we use about engaging the frontline staff. These are our results. After 18 months, the hospital that was looking at catheter-associated bloodstream infections that dropped 81%. The one looking at urinary tract infections from Foley catheters that dropped 100%. Falls that dropped 22%, pressure ulcers 20%, surgical site infections 20%, and hand hygiene was up 43%. One of the nice things about the American healthcare system is that everything gets broken down into money. That reduction in falls alone more than paid for this collaborative twice over, just the falls reduction. We saved them enormous amounts of money, and the only cost of this was us working with them. So let's look a little bit at pressure ulcers. Here's a good example of a hospital that things got worse before they got better, and then they dropped down to zero. What happened here was the ward got very excited about pressure ulcers and started to diagnose them all over the place where there weren't actually any pressure ulcers. And they developed their own team to kind of vet what others were saying to make sure they were real or not. So then their rates dropped. We worked with 6 hospitals on falls. They all came up with different ideas. None of these ideas cost money. In this hospital, they only had one size of no-slip socks. So they ordered 3 different sizes. In this one, patients were being woken up at 4:30 in the morning to draw blood every day on the geriatrics unit. Very, very few nurses around at that time. They'd wake up, they'd have to run to the washroom, and then they would fall. This one over here, they would actually include talking to the patients about their fall risk and bedside report. This one I love. This hospital had already invested in falls monitors. You know, you put them on the mattress. If the patient starts to move, the alarm goes off at the nursing station. But what was happening at night is the nurses were systematically unplugging all of the monitors because they didn't like the noise. And so their innovation was to plug them back in again. I already mentioned this one, the no pass rule, the idea if the light goes on. This one, they were feeding back falls in terms of number of falls per 10,000 patient days. What the hell does that mean? What the frontline staff came up with was number of days without a fall, and they posted it right there on the nursing station. These are all simple ideas. All of them came from the frontline staff, and they're not necessarily transferable. Or they might be transferable, I don't know. But the reasons why this stuck was because it was their idea. They're all nibbling away at the problem. They're all taking different routes along to the outcome that we wanted. So overall, if you look at the units that were involved in this, we've seen a slow, nice decrease in falls, whereas the other ones were actually going up. So when you do this work, and you work with frontline staff like this, people take time to think. Rather than just get it done, they start engaging with their frontline staff. Social proof, like the stories I'm telling you, become incredibly important. Think back to that slide I talked about complex systems and how to make them better. Relationships become incredibly important, and rather than ignoring them, we seek them out. Who can I build bridges with in order to make this better? We have found culture change to be extraordinarily simple. When we first started working with these American hospitals, they're all direct competitors of each other. They had never been in the same room together. They're busy swallowing up each other's hospitals. Staff we started working with all got fired the next week. It was a very difficult group to work with. By the end of the 18 months, they're all in a room cheering each other and talking about their own experiences and sharing things that have worked, things that haven't worked. We've seen a total transformation in how these teams interact with each other, and all it involved was us talking to them. It's not something we could have done if we would have tried to force it on them. Here, what we've seen is leaders need to step back and listen to the wisdom of their frontline staff, come up with the ideas that are going to work. And we've really seen the movement towards bottom-up leadership from the front line. I'll leave you with this quote from Einstein. Insanity is doing the same things over and over again and expecting different results. What I've found in patient safety is we tend to keep doing the same thing over and over again, even though often you know this isn't going to work. How many of you have gone into a situation where you're trying to implement something where you kind of know it's not going to work? I've done that 100 times in my career, and I finally gave up and said, why don't I try something completely different?